Hi everybody, welcome to the abstract session for the BSE. We've got some tough competition this morning, so I'm really pleased to see so many of you here. And you are the research elite, so welcome to the session. I think we've got some really interesting talks. And this year was really good because we changed some of the guidance about the way that abstracts were submitted and what was expected of the people that submitted abstracts. And we had a record number of submissions, so you guys have done really well to reach the top 6, so congratulations. And we're really interested to hear what you have to say today and all of your findings. So thanks so much for being here. We're really proud of the level of submissions this year. They were a much higher quality, and it really just shows the change in research over the years, particularly in recent years. And hopefully some of that is to do with us forming the Research and Audit Committee, which has helped drive some of these things forwards. So each speaker is going to talk for 10 minutes, and then we've got a few minutes each for questions. I've really appreciated people putting questions on Slido. The link was just up there. I don't know if we can pop that back again. But obviously you guys will be used to reading research. You can appraise each other's literature. Please put in questions and we'll ask them after each talk. So first up, we have Dr. Gu, who's going to talk to us about early LV systolic function and whether it's a more sensitive predictor of adverse events in heart transplant recipients. Thank you.
Looks like it's not me.
Do we have to do this order?
Oh, there we go. Perfect. Yeah, lovely. So that's me now. Brilliant. Okay. Right, so good morning, everyone. So it's my pleasure to be here to present our work in the two very interesting areas. So the first one, is a laser I can use. So this one here, isn't it? I see. Okay. Yeah, so the first part, obviously, is the heart transplant. And so the heart transplant is a very unique cohort, and it's very interesting to look at. And the second part is the early systolic function. So these are the two main interesting areas in my study. Right, so let's talk about heart transplant first. So heart transplant is a very unique treatment. So obviously, so people with advanced heart failure, so when we cannot correct their heart function or provide their surgical or medical treatment for them, so the ultimate treatment would be to give them a new heart, to transplant the heart. And in terms of heart transplant, and in terms of the donor, so it's different from renal kidney transplant. So we cannot have a living heart transplant donor. So that's why it's quite crucial to find suitable candidates to go through this operation. And after the operation, and it's very important to monitor their graft function very closely because people may die mostly because of this graft rejection. That's why we need to monitor the function and there's a possibility of rejection in those people. And currently, echo is the first-line imaging modality in those patients. But the current clinical and diastolic parameters from conventional echo measures, some studies are showing that it's not optimal to detect this early graft rejection. Therefore, I would like to introduce the second interesting part, early systolic function, which is so-called first phase ejection fraction, which I invented a few years ago. And we've been testing this new marker in various of different conditions. You can see we've got a few publications around aortic stenosis, in patients with hypertension, and also in cardiac resynchronization therapy, and also we extended to children with hypertension and chronic kidney disease as well. So now, what is this first phase ejection fraction, or is so-called EF1? Conventionally, when we look at the function of the heart, so we look at the volume at diastole and the volume at and systole, then obviously the gold standard measure as ejection fraction is the change of the volume between those two time points. However, you can see the heart contraction is a time varying phenomenon. It changes over time. If we only focus on the beginning of the contraction to the end of the contraction, we miss a lot of information how the heart managed to achieve from the beginning to the end. So like this volume over time curve, okay? So let me show you an example to start with. So this is one patient, and this is the volume over time curve, end-diastole to end-systole, and these are the numbers. So you can easily work out for this particular patient, ejection fraction 60%, okay? So the second patient, again, so these are the numbers, probably a little bit more difficult, you have to use your calculator to work it out now. I'll give you the figure, 60% again. But if you look at the pattern of these two curves, they're completely different. But if we look at the ejection fraction, identical. Can we clinically say these two patients got the same ejection fraction, and so therefore they have the same systolic function? We don't know, probably not. So then I introduce a new measure, which is focusing on the change early on during contraction. So the volume we detect from here is so-called a V1. It's quite early on during the ejection phase. How do we find out this V1 point? So we first of all, when I first invented, I used this pressure, central aortic pressure waveform. So the first peak of the pressure waveform in the aorta, so which is actually happening primarily driven by the contraction of the ventricle without any backward flow from the aortic system. So that this time point probably would be the best point to look at, has got physiological meaning of it. So then this point theoretically would be equivalent to, when you look at aortic flow, the time to peak aortic flow is the time equivalent to this first pressure waveform. So therefore, so we look at this equivalent time point on the volume. So we used a similar equation to ejection fraction to work out the volume difference between the end of diastolic volume to this V1 volume. So then we can work out this first phase ejection fraction, which is ejection fraction early on during systole. Okay? So now let's go back to the same example. If we look at this V1 point for these two patients, V1 92 mil for the first patient, EF1 8%. 622 for the second patient, EF1 30%. You can see it's a massive difference between the two cases. So in the second case, you see half of the ejection fraction able to be achieved early on during systole. But for the first case, only 8% achieved. So which means the ventricle has to sustain the contraction towards the end of systole, which makes the muscle more stressed towards the end of contraction or towards the end of systole, may lead to impairment of diastole because it has got a lot more work to do towards the end of contraction phase. So that's the importance of this EF1. We'll look at the function early on during systole, okay? So now let's go back to the study. So this study, we prospectively recruited just under 300 heart transplant patients from the largest heart transplant center in China. You can see that's the central China, and it's, the hospital is Union Hospital in China, in Wuhan, so where COVID first started, okay? And so we followed them up for just over 3 years. And the primary endpoint is including both death, about 20 patients died, and graft rejection, 15 patients, okay? So now we analyzed their echo, and we measured their EF1 from the volume and from aortic flow using this equation which I introduced earlier. Let's have a look at some results. So first of all, let's have a look at the difference between patients who had events versus those who did not have events. So you can see the demographics, they're pretty much identical across. The only difference we can see is their creatinine and BNP levels. So in patients who had events, they have elevated creatinine and BNP, which makes sense. They've impaired kidney function, and also elevated BNP may suggest they have some form of heart failure. Okay. Now let's move on to the echo parameters. So no difference in end diastolic volume, no difference in stroke volume index. You can see so in patients who had events, they have enlarged left atrium, and they have slightly lower ejection fraction, but well above normal range. And they have lower longitudinal strain, and they have a slightly lower E prime ratio, okay? And the most striking finding is you see EF1 here, despite they have got pretty similar, although statistically different, but relatively normal ejection fraction, their EF1 is dramatically lower compared to the patient who had not events, okay? So now, if we look at this ROC analysis, So the area under the curve is the thing we're looking at here. So the green line on top, that's EF1. So you can see they have got largest area under the curve, followed by this one is strain, okay? Followed by strain. Strain is less sensitive in detecting events compared to EF1. Then followed by ejection fraction, okay? And the optimal cutoff value using the ROC analysis, which is 25.8% in this cohort, which is pretty similar to this aortic stenosis cohort we did before. We had optimal cutoff value 25%. It's quite similar. And then when we use this optimal cutoff value in the Kaplan-Meier survival analysis, then we found that in patients who had a relatively normal EF1, no one had, only one patient had event. And so the majority, as time passed, so you can see the difference between the two groups. Okay, it's a massive difference. So now in the Cox regression model, so this is a univariable model. And again, so the most predictive values, we can see that BNP, creatinine, left atrial volume index, ejection fraction, strain, E prime, EF1, and TAPC. So these are probably most of the parameters are actually we have already known from the previous studies. Okay, so but the interesting bit is when we put in the multivariable model, so when we only include these three, EF, strain, and EF1, so only EF1 left to be the most significant predictor in the model. Then when we add more into the model, again, so EF1 remained as the most significant predictor of event in those cohort, okay? So finally, in conclusion, what we know now is, so in the heart transplant received patients, so conventional measures, although we can see there's some difference in the patient who had events versus no events, but they are, when we look at, put all the confounders in the model, so they are not significant. So only EF1 as an early systolic functional measure is the single and the most powerful predictor of events in the heart transplant recipients. And if these findings can be confirmed in the large multi-center study, then maybe we can use EF1 as a guide to monitor their graft function and also provide a better treatment for those patients. Finally, I would like to thank the financial support from NRHI and the BHF, and obviously the hard work from my collaborators in China. Thank you.
Thank you so much. That was really interesting, and what a fabulous collaboration that you created. That was really good. Thank you. I don't know if anybody has any questions in the audience. I know that we've probably got a few, but I'll hand it. Do you want to go first?
Yeah, no, fantastic presentation. I'm interested in the data you acquired and collected, which is all from one centre. Is that right? The centre in China.
Yes, one centre.
Who analysed the data?
Colleagues in China.
Okay, and did you assess reproducibility? Was it a single observer? Was it?
Yeah. So we've done the reproducibility test, but not including this data. But we've got a publication on the way, so it's in the paper. Yes.
Okay, and what was the variability? What was the?
Oh, I can't remember that figure on top of my head, okay. But they are actually quite reproducible. And also, my colleague Dario, who presented a EF1 a few years ago in the BSE, and I think he won the Young Investigator that year, and he presented data from GSTT from St. Thomas's. Then we compared the 2D versus 3D EF1 measure, and we showed a good reproducibility by both in 2D and 3D, but 3D has got better reproducibility. And in terms of time-consuming wise, 3D actually is quicker to do compared to 2D. Yeah.
Okay, thank you.
Can you shed any light on what you think the mechanisms behind this might be? Obviously, the beautiful sort of curves that you used to illustrate at the beginning potentially suggest that there is more passive sort of change in the contractility of the muscle rather than a more active element. Is that are those the findings that you've kind of drawn upon? Or?
Yeah. So my understanding of this mechanism is, so conventionally when we define systole, so we look at the aortic valve or the flow. So from the beginning of the flow through the valve to the end of the flow. But that's from the hemodynamic perspective when we look at the flow. But from the myocardial perspective, maybe so the myocardium would only work at a certain time period during the aortic flow going out. So maybe the myocardium stopped working already early on during systole, and for the rest of systole, or let's say for the rest of the period of time when the flow is still going out, but the actual force on the myocardium has reduced already, or stress, let's say. So the study we've done previously, we show that the myocardial wall stress during systole, so in the patients with a relatively good ventricle, so the stress, time to peak stress, happens early on during contraction phase. And for the rest of systole, the wall stress on the myocardium starts to relax already. And for the patient who had a failing ventricle, so the stress is staying towards the end of systole in order to maintain their overall ejection fraction, then potentially leads to diastolic impairment. So my hypothesis is always that, so the heart contraction probably, so the heart should only work quite early on during systole, and for the rest of systole, it may have already going to relaxation phase, even when the flow is still going out.
And have you been able to investigate that any further with any temporal strain measurements?
Yes, so we're still working on this, the time-varying myocardial wall stress, and also we're working on some animal studies. So we can actually, because with animals we can do more compared to humans. So then we can probably find out the real mechanism why this early systolic function is quite important. What's the cause of it?
Lots in the pipeline then.
Can I just ask one last question?
Yeah, of course.
When I think about ejection fraction, I think it's very much related to end diastolic volume. And I'm just wondering, is this likely to be less related to the end diastolic volume?
No. So it is also, so EF1 is actually a different way of measuring ejection fraction. It's also preload dependent. And when we've done study, we've done some intervention in those patients, we give them a sublingual GTN basically, and to reduce their preload. And we found that with the reduction of preload, so there is improvement of the early systolic contraction and also improvement of diastolic function. So it's all it's preload dependent. So maybe in some heart failure treatments, so we could use diuretic and use EF1 as a guide of treatments to see how this reduction in preload would improve their early systolic function.
Yeah, sounds good. Absolutely.
Thank you so much.
Okay.
Oh, sorry, did you want? Okay. Thank you.
Fantastic. Okay, so next up we've got Asil Al-Fahid. Asil's presentation is inter-technique agreement and test-retest reproducibility of assessing left atrial function. And this is a comparison between transthoracic echo and cardiovascular MRI.
Yes, thank you. Good morning. Yeah, this is my slide. So I'm Asil Al-Fahid, a cardiac physiologist and a PhD candidate at the University of Leicester. Thank you for the opportunity to allow me to present some of my PhD work today. So as we know, both echo and CMR studies have shown left atrial dysfunction to be an independent predictor of adverse outcomes in multiple cardiovascular conditions. As you can see from the illustration, the left atrial function is quite complex, and it consists of 3 phases. So during ventricular systole, the left atrium acts as a reservoir, which is the phase in blue, as you can see from the illustration, receiving blood flow from the pulmonary veins due to a decrease in the filling pressure, leading to an increase in left atrial size. So the conduit phase occurs during early left ventricle diastole, which is the phase in green, and reflects passive emptying of the left atrium into the left ventricle. The third phase, which is the booster pump or left atrial contraction phase, and this is the phase in orange, occurs during late left ventricle diastole, resulting to an active left atrial emptying. So both modalities, echo and CMR, can be used to assess the left atrial function. However, there are several differences. So echo is superior as it has high temporal resolution, and many studies shown good intra and inter-observer reproducibility in terms of left atrial strain assessment. In contrast, echo showed limitation in assessing the left atrium, as we know, because the left atrium located in the far field, and especially that happens with a patient with poor image quality. So on the other hand, CMR is known for its high signal-to-noise ratio and contrast-to-noise ratio. and this allows easy delineation of the blood pool and the myocardium. Accordingly, so CMR is well known to be the gold standard for the volumetric quantification. However, the frame rate of the CMR affects the left atrial strain assessment, and by missing the true peaks, as have been shown before in the literature. So keeping this in mind, both the agreement between echocardiography and cardiovascular magnetic resonance imaging to assess the left atrial function is not well established. Also, the techniques are lacking test-retest reproducibility data for left atrial function assessment in any patient group. So for this study, we aim to investigate the inter-technique agreement and the test-retest reproducibility of both echo and CMR, derived left atrial strain and volumetric assessment in people with and without cardiovascular disease. So in order to achieve that, patients with severe aortic stenosis, asymptomatic type 2 diabetes, and healthy volunteers were prospectively recruited as part of ethically approved research studies in a single center. So the participants underwent echo and CMR on the same day for inter-technique agreement assessment. A separate cohort of people with type 2 diabetes and no cardiovascular disease had same-day echo and MRI, and invited for a second visit to repeat the scan after 2 weeks, and this for the test-retest reproducibility assessment. So blinded image analysis was performed by me, and I followed the same methods on both imaging techniques. As you can see from the illustration, left atrial volumes and the emptying fraction were calculated using the biplane area length method. Left atrial strain was measured at the 3 phases from the strain curve as illustrated for reservoir, conduit, and booster pump. And the average measurement of the 4 and 2 chamber long axis views were used. We've used the standalone dedicated software. So echo images was analyzed using TomTech, and we've used MIDAS for CMR images. So off to the results. Of the 222 consented participants for inter-technique agreement cohort, 30 were excluded due to poor image quality. So this left us with 192 participants who had analyzable echo and CMR scans, with a mean age of 57 years and 66% were males. 10 people with type 2 diabetes were recruited for the test-retest reproducibility cohort, and all had analyzable echo and MRI scans, with a mean age of 65 years and 50% were males. So in this table, we can see the inter-technique agreement assessment of the left atrial volumes, CMR versus echocardiography. The volumetric parameters are in the top 3 rows, and then followed by the strain parameters. So the data show the left atrial volumetric parameters were significantly higher on CMR, while there were no significant differences in strain parameters, echo comparing to CMR. In terms of the agreement, all left atrial parameters showed moderate agreement between imaging modalities, and as you can see it from the intra-class correlation values. Here we can see the test-retest reproducibility of the left atrial volumetric parameters for echo on the right and CMR on the left. So CMR reproducibility was excellent for left atrial volumes, and it was good for left atrial emptying fraction. In contrast, echo showed left atrial volumes with a good reproducibility, but poor for left atrial emptying fraction. In terms of the strain, left atrial assessment, CMR showed good reproducibility for reservoir and booster pump strain, but moderate reproducibility for conduit strain. In contrast, echo conduit strain had good test-retest reproducibility, but poor reproducibility showed for reservoir and booster pump left atrial strain by echo. Here we can see the blind Altman plots for test-retest reproducibility of left atrial strain parameters, starting from reservoir and then followed by the conduit and then booster pump, showing echo on the right and CMR on the left. So overall, the plots show similar reproducibility by both modalities, with echo showing the narrowest limits of agreement in terms of conduit left atrial strain. So we appreciate that our study has several strengths and limitations. So the strength of our study is it's the first study that extensively assessed left atrial function by same-day echo and CMR on the same cohort of patients. And also, it's the only study that compared test-retest reproducibility of both imaging technique for left atrial assessment. We conducted image analysis blinded to participant information and to the other imaging technique. Our heterogeneous cohort allow wider overview, and thus it's more clinically applicable. On the other hand, our limitations are different echo and MRI scanners could introduce some variability for inter-technique agreement comparison. However, this could be the case in clinical practice, as we all know. The sample size for the test-retest reproducibility investigation is small. However, in the sample size calculation, 10 subjects allow 80% power for intra-class correlation of 0.7. So intra and inter-observer reproducibility analysis were not included in this study. However, the test-retest assessment incorporates the intra-observer variability as the analysis was done by the same observer. Lastly, the inter-vendor differences between analysis software are not known, so further studies are needed. So in summary, in terms of left atrial volumetric assessment, echo and CMR are not interchangeable, with a large positive bias for left atrial assessment by CMR. Test-retest reproducibility of both echo and CMR is good to excellent for left atrial volumes, but poor for left atrial emptying fraction on echo. In terms of left atrial strain, minimal bias with moderate agreement between echo and CMR was seen. And test-retest reproducibility of CMR is moderate to good, and echo had good reproducibility for conduit left atrial strain. So overall, we can summarize that these results favor the use of CMR for assessing left atrial function in longitudinal study as it allows lower sample sizes. However, for left atrial volumes, either modalities can be used but not interchangeably. At the end, I want to thank my supervisors, the co-authors of this study, and all the members of Cardiac Imaging Research Group and the PRC at Glenfield Hospital. And lastly, my sponsor who gave me the opportunity to study in the UK. Thank you for listening.
Fantastic presentation and a wonderful study. I think it's fantastic that someone's doing reproducibility work, but thinking more about test-retest, because that's the clinical value, right, in terms of serial assessments and so on. I'm just interested in terms of, because it is test-retest and there was approximately 2 weeks between the tests, how did you control for confounding variables, physiological variance, and so on?
So those patients with type 2 diabetes, but because it's not interventional, so we couldn't give them any interventional medications. Of course, there will be some variability because of the hemodynamics. We've tried to keep it the same, to have the echo and MRI in the same distance from each other, like starting with echo and then MRI when we bring the patient for scanning. But to be honest, this is the nature of the technique, so
sure.
This is what we could.
Sure, but I mean, in terms of, did you control the time of the day, for example? Did you bring them in the morning?
No, but most of the patients are coming in the morning. But to be honest, we give them always the chance if they want to come in the afternoon. Yeah, so it could be a limitation, to be honest, yeah.
Okay, we've got a question here as well.
We have. What was the rationale for choosing biplane area length volumes over Simpson's method of discs?
Yeah, so I totally agree with that, because we know the limitations of using the biplane, but we've used it because we want to have a standardized method on both imaging techniques. We couldn't do Simpson's on CMR, because in CMR, if you want to do the disc method, it will be from the short axis, which is a completely different thing to do. So the main reason we've chose the biplane is to standardize the method between the two, echo and MRI.
Okay, another one here. Did any of the patients have AF?
No, not our patient have AF. We've excluded the patient with AF, yeah.
Okay. can I just go back to the reproducibility question again? just one quick thing. What were the heart rates like on those two? Were they the same? Was it a similar heart rate for the test 1 and test 2? Were they the same heart rate?
Well, I don't have the results right now, but we've checked that, and there isn't any significant difference between the two heart rates.
Okay.
Between the two tests, test 1 and 2.
And all your technical settings were the same as well,
Yes.
strain rates
Yeah.
and so on?
Yeah, and we've used the same scanners as well.
Okay, thank you.
I think there's a question in the audience. Do you want to ask?
Yeah.
Very nice presentation.
Thank you.
Just got a question. So in terms of your population, why did you use patients with type 2 diabetes in this study? Obviously, why this population?
Can I just repeat that just for anybody
Yeah.
who's listening outside? So it's just a query about why you used the different populations that were included in the sample.
Yeah, so because we are interested in our center in Glenfield Hospital by recruiting patients with AS, and we have studies with different patients with AS and type 2 diabetes. So this is the reason. And because it's all prospectively recruited as well.
Have you done any sample analysis to see whether there's any difference between diabetes, AS, and health controls in terms of echo?
Yes, we've done that. Actually, I have the slide in case anyone. So here we go. Yeah, so this is the inter-technique agreement between the disease or the subcohort. So we have aortic stenosis, type 2 diabetes, and then healthy volunteers. So at the beginning, so the volumetric assessment, still the difference is there between MRI and echo. And in terms of the strain, we can see that diabetes has the majority or the significant differences between echo and CMR. The agreement, AS cohort shows the best agreement between echo and CMR. But to be honest, I don't have actually the reason why.
And finally, so we can see that the massive difference between the volume measurement between echo and CMR across the whole cohort people here. So what's the explanation for that?
You mean why it's...
So for example, there's a 30 mil difference between the CMR and the echo
Yeah.
in aortic stenosis, so 91 versus 60. There's a massive difference between the two techniques.
Yeah.
So what's the explanation for that?
So this, to be honest, this is it was acceptable, to be honest, because the MRI is the gold standard to do the calculate the volumes, and because the image quality, this is the first thing that we face in echo. And as I've said earlier, one of the limitations of echo doing the calculating or quantifying the volume of the left atrium is located in the far field. So it's barely we can see it. Sometimes it gets foreshortened. We've tried our best to get the best images that we've got, and also we've excluded patients with poor image quality that we couldn't analyze. But yeah, so this is expected, I think.
So in that sense, so obviously in echo, we always look at left atrial volume index, but there's a massive difference between CMR volume and echo volume. So we should probably rethink about, we only look at left atrial volume. So obviously people may have a large left atrial volume from CMR, but normal volume from echo. So how do we decide whether this patient has a large volume?
It would be interesting to see if there's any clinical implications, I suppose, for whether the diagnosis or anything would be changed clinically based on the findings.
Yeah.
But I think this is an excellent starting point that you've obviously clearly, looked into all of the data really well, and it might be worthwhile trying to see if you can collaborate with any of the centres to increase the data pool a little bit more, because you'd be able to look into that a bit further. So
Yeah, great.
we've definitely got some data at Leeds, so come and see me afterwards.
Yeah, great, thank you. We appreciate that, the collaboration.
Brilliant, thank you so much. So next up, we've got Imogen Wilding. Surprise. So Imogen's going to be talking to us about how could we offer more prudent echo services. So looking for a retrospective pilot study of level 1 echo to exclude significant disease in patients referred from primary care.
Yes, so as you said before, that's the title of our study. So this was a small project from the Echo Lab at Swansea University, and it's part of a much larger programme of work around echo quality improvement and service innovation and research as a whole. So my name's Imogen, and I performed this small pilot project as part of my undergraduate dissertation, and I was supervised by Dr. Emma Rees, who you might have heard speak yesterday here. So again, it is part of this larger programme of primary care transformation. So I'm presenting this data on behalf of the team who you can see behind me on this slide. So I have just graduated this past summer, and it's my first time kind of presenting at a conference, and my echo knowledge probably isn't as good as any of you guys out here. So Emma's on hand for questions at the end that you might have. she told me to say that. So I just wanted to give a little summary first of what actually is a level 1 echo, because I'm not sure if anyone kind of fully knows. So I won't read all over it, but the BSE website obviously has the minimum data set there if you're interested, and lots of educational resources as well. So why did we perform this study? So there is an increasing interest in the utility of level 1 scans in routine care, and obviously we were driven by a number of factors. So firstly, the workforce crisis. So the BSE survey of the echocardiography workforce in the UK asked echo leads across the country, what's the main reason for there being vacant posts in your department? 53% of respondents answered that they'd advertised but failed to appoint vacant posts. So this obviously there just aren't enough echocardiographers to meet the demand, and obviously following the pandemic as well, departments are suffering a lot more staff absences. So there's also been a rapid rise in echo demand. So the number of echoes performed in the UK has increased by 3% annually over the last decade. And as of February this year, there were nearly 12,000 patients in Wales waiting for an echo, and nearly 3,000 of these patients were waiting over 14 weeks to be seen. So when we were evaluating our data, we found that a large proportion of GP referrals were to exclude disease in those with non-specific signs and symptoms. So if we're able to do this accurately and efficiently using the level 1 scan, there's potential obviously to reduce waiting times and stress on health boards. So prudent healthcare as well. So there's increasing recognition that services should provide prudent healthcare. So this is obviously aiming to prioritise those with the greatest need, doing just what's needed, no more and no less. And if we're able to rule out cardiac causes quickly and accurately for very common presenting complaints, and being able to give GPs a very definitive answer to a clinical question, that would really promote prudent healthcare. However, there are concerns that introducing a level 1 scan in this context might result in misdiagnosis or misdiagnoses. And finally, there's insufficient evidence to change practice at the moment, so we wanted to add some kind of balanced information to this debate, and we designed this small pilot study to do so. So, our study had 3 aims. We wanted to identify the proportion of GP referrals which can be answered by a level 1 scan, whether an echocardiographer can accurately determine when to progress to a level 2 scan, and whether significant pathology is missed when the level 1 scan was felt to be sufficient. So our methods. So we did run this pilot study for the GPs in the Swansea Bay Health Board between July 2021 and February 2022. And this service was specifically designed for patients without an existing diagnosis of cardiovascular disease, but with new signs or stable symptoms such as shortness of breath on exertion, murmur, or peripheral edema. So the service operated on a part-time basis, and 263 echoes were performed. We then randomly selected 31 patients for the group for our study. An echocardiographer reviewed archived images, selected the level 1 dataset, and stored these anonymised images to a DVD. A second echocardiographer, who was blind to the level 2 dataset and report, then reviewed the level 1 dataset and completed the BSE template report. No studies were excluded, and after the unblinding, the results of the level 1 and the level 2 datasets were compared. So some indications and patient characteristics here. You can see that the majority of the referrals were to exclude new LV dysfunction in those with new exertional symptoms. So that's 48% there. 32% of our referrals were to exclude valve disease in those with murmur, and 10% were to exclude structural heart disease in those with neurarrhythmia, and we do have 10% as other there. So 58% of our patients were female, and the mean age was 68, and these clinical characteristics were similar to that of the broader cohort. So our results. In our sample, 97% of the level 1 dataset scans were diagnostic quality, The echocardiographer determined that in 68% of studies, the clinical question could be answered by a level 1 scan. So this obviously means they recommended escalation to a level 2 scan in 32% of cases, or 10 patients. So of these 10 patients, 7 of them were over the age of 70 and had valve disease. So the level 2 scan was needed to classify the severity of the disease. And finally, no clinically significant diagnoses were missed by the level 1 scan. Obviously, there are limitations to our study. We did have a very small sample of just 31 patients, and obviously this means the results might not be representative of the wider population and therefore not reliable. As we selected our patients randomly, not all indications were assessed using a level 1 scan, meaning the clinical application of the scan in this context obviously wasn't assessed. And although the random sampling does reduce sampling bias, it means that some patients with poor or missing views were included in the population. So a full kind of true assessment according to the minimum data set couldn't always be made. However, obviously as the results show, even in these cases, no clinically significant findings were missed. So how have we interpreted these results? In primary care, if patients do not have a history of cardiovascular disease and the GP would like to exclude that as a cause of non-specific signs and symptoms, a level 1 echo may be sufficient for excluding LV dysfunction, but only when performed by an accredited and experienced echocardiographer who's using good quality equipment. The ability to escalate to the level 2 scan during the appointment was important, so this could obviously pose logistical difficulties for kind of maximising that workflow efficiency. And in our small sample, obviously patients over the age of 70 with suspected valve disease frequently needed that level 2 scan. Obviously the prevalence of valve disease in older people with these exertional symptoms is high, and we need to classify the severity to inform management. So this kind of demographic wouldn't be suitable for the level 1 scan. So we hope that this data will provide some useful insights, but obviously as previously discussed, there are limitations. So larger and prospective studies are needed to confirm that utility and any unintended consequences of the level 1 in primary care. Our service did specifically see clinically stable and low-risk patients that had a very narrow range of defined indications. So this does limit the generalisation of the results to different settings. However, obviously a service in which patients can be assessed faster and in a community setting may help to alleviate worries patients have about coming into hospital, which obviously have kind of escalated over the pandemic. So overall, we believe that this study has demonstrated the potential that level 1 echoes might have in primary care and can kind of provide a foundation for future research that may be able to offer patients a more prudent healthcare system. So thank you for listening, and obviously if you'd like to chat more informally, I've got a poster up in the room downstairs, and obviously Emma's here at the conference, so she's happy to be approached. Thank you.
Thanks, Imogen. That was brilliant. I think it's really interesting work, and it's clearly going to lead on to a lot of further work, I'm sure. What I find really interesting is the way you randomly selected 31 patients. Can you explain that a little bit further and how the random selection was achieved?
So obviously we had our, I think it was it 263 patients off the top of my head. So we just used random number generator. Obviously the patients were all assigned a number on our spreadsheet for our data set. We use a random number generator, and we didn't exclude the patients for poor image quality or anything like that. But obviously then that did lead to having data sets that were incomplete in some cases.
Which is interesting in itself because it's a real-world investigation, isn't it? So that's important as well. Would it be entirely unfeasible to go back and perform the same study on the whole 263?
That's a good question. Emma works in the clinic day to day. She might have a better idea of whether that would be unfeasible.
How long did it take you to do this?
Yeah, I was doing my degree at the same time. So if I wasn't doing that, it wouldn't have taken as long. But obviously, to go through that whole cohort, we would maybe need more staff. I think it definitely would be feasible, and obviously that would be able to contribute more to the research. But I think instead of retrospective study, using a prospective study is obviously the next step, I think.
Brilliant, yeah, absolutely. And sorry, can I squeeze in
Yes,
just
go
one
on.
more question? I was just really interested that it seemed to be the patients that needed a bit more of a valve disease assessment that went on to need the level 2 scans. were they indicated for the query of valve disease right at the beginning? Could we have known right at the beginning that they should have just gone straight to a level 2 scan?
Yes, so the indications were murmur for these patients. So obviously they've seen their GP in clinic and been sent for the scan. So obviously they did have the comprehensive scan. But yeah, obviously as we use random sampling, they were included in the sample. So obviously when going through the GP referrals, we can kind of think, right, they're not suitable for the level 1 scan, and keep it for the patients, you know, that are much younger, you know, 20s, 30s, soft systolic murmur. If we can just use that scan, you know, pop the probe on and be able to rule out significant valve disease for those patients, it would obviously reduce the amount of people going to hospital and having that scan.
Thank you.
We've got Dan.
Yeah, hi. Thanks, Imogen. That was a great presentation and really useful data that will lead on to really important work. I worry with level 1 scans about missing diastolic dysfunction. 70% of the patients had breathlessness, and there are a huge proportion of patients that are being admitted to our wards, diastolic heart failure, and there's potential treatments now. It's just something to think about when you go on to do other protocols, maybe putting in a measure of diastolic function in addition to other measures.
Yeah, definitely. Obviously, we didn't assess diastolic dysfunction. Obviously, Doppler's normally used, and with just colour Doppler being included in this. But obviously, an expert who was BSE accredited and experienced did perform the scans. And obviously, they looked at the left atrium for any dilation and LVH. And obviously, if that's absent, you can hopefully say that diastolic dysfunction isn't likely. But obviously, it's not a true assessment, just doing a visual kind of exam in that
Yeah,
regard.
I can answer that, Imogen, because the echocardiographer who reviewed the scans, if she felt that from the 2D images there was likely to be diastolic dysfunction, she would escalate the blood. They would be appointed an escalation group. And one of the things that we were thinking with our prospective look ahead is that because we're using a high-level echo machine, we can easily add some Doppler images and be able to start to think about that.
I think that'd be really important as well. Absolutely. You know, it's, I mean, if you think about 2D in terms of the criteria for assessment of filling pressures, it's only one component of it, of course. And, you know, I think that's a really pertinent point. Yeah.
Thank you. Very, very nice presentation. I just got a question. So the reason we performed this study, I guess, probably is mainly, first of all, to cut down the waiting list and also to not impact on patient outcomes, for example. And my question is, so how long does it take to perform a level 1 scan compared to if you do a full standard echo?
So I believe, and Emma might be able to correct me, but I believe it's 10 to 15 minutes to kind of perform that scan. And kind of to be able to use that in primary care was the aim, and you know, keep patients out of hospital.
Sure. So for example, if we say that if we do a standard echo list according to, so perform a level 2 scan, standard echoes, then we probably could do 10, 12 patients a day. Then if we cut down to 15 minutes per scan, then we could probably even triple the number of patients we see in a day. And so what happens for those who've been referred, so we found that they need a level 2 scan. Are they going to go back to the GP and wait for another referral for a level 2 scan, wait for another 14 weeks for that? Or what's the clinical pathway of performing level 1 scan versus just go straight to a level 2 scan? And I think that's probably...
I can see my colleague behind you is...
Yeah, if I could just add, because obviously Imogen only just graduated. She's not working in echo yet, but you're doing brilliantly with the questions, Imogen. Really well done. So yeah, our rationale for doing this is not about reducing the backlog. Our rationale was that actually when we looked at the reports that were going back to the GPs, for those where we were just excluding disease, the GP was getting more information than they needed, and that was having an unintended consequence for some of the echo findings, triggering a cascade of investigations that weren't needed. So our rationale is to provide more prudent health care and to give the GP the answer they want, but no more information from that. And we're not looking at workflow in this study. Separate point.
Okay. We've got one last quick question at the back there, if that's okay.
Sorry, I'll be quick. Thank you, that was really nice. I guess maybe in fraction of a lot of the questions, is it possible to kind of introduce this approach into more of a community-based setting? Because it seems like you have very high sensitivity in your kind of outcomes. So, you know, and addressing the whole second referral issue, introducing a more community-based pathway offer more potential for addressing the questions of the study?
Yeah, definitely. I think, you know, the being able to perform it in a community setting is the aim. The clinic in the university is kind of community. It's not a hospital, it's literally just in the uni. But obviously you do need those BSE accredited and experienced echocardiographers. So I think that would be where the problem would lie, finding the workforce to obviously carry out that number of scans to have an impact in the community, I think.
Thank you.
Thank you.
Yeah.
Wonderful, Imogen. Okay, next up we've got James Willis. His talk is entitled The Right Assessment, Utilising Novel Atrial Markers to Support Pulmonary Hypertension Investigation.
Thank you for the opportunity to come and talk about the work we've been doing looking at right atrial strain in our patient cohort with pulmonary hypertension. We know that the gold standard for the assessment of pulmonary hypertension is right heart catheterization, and we can see that over the years, actually what's happened is the threshold for the assessment of pH has changed, and this really is in response to the need to be able to detect sooner the patients who might have pulmonary hypertension. So we've seen a reduction in the mean pulmonary artery pressure and a change in the wedge pressure as well. But this is the invasive measure, and so we want to provide some more non-invasive tests prior to the patients getting to the cath lab, and this is really where the BSE protocol for the assessment of pulmonary hypertension comes into play. And for those of you that aren't familiar with it, it works on a sort of increasing probability premise, and so we look at three key areas: the ventricles, the pulmonary artery, the IVC, and the right atrium. And there are key sort of physical changes that occur within the heart that we use to grade grade the echo probability of pulmonary hypertension into low, intermediate, or high. Now, in the time we actually put together this presentation, the ESC very helpfully decided to release new criteria. We know that in 2022, in August at the end of the month, these were released at ESC, and we see that there's two updated criteria that have actually come into play here. So we've got, in the ventricles category, the TAPC divided by the systolic pulmonary artery pressure ratio, and this is a recognition of the RV-PA coupling. And we can also see that there's a PA diameter measured against the aortic root diameter as well, which I believe is based on some CT data. And so what we really want to do with our atrial strain measurement is try and fill this empty box down here in the right-hand corner. And see whether or not right atrial strain is useful in assessing patients with pulmonary hypertension and looking to improve the probability assessment that we can do at the early stages of the non-invasive assessment of pulmonary hypertension. So we know that actually increasing right atrial pressure is an established marker of RV failure, but not a lot is really known about the RA mechanics. So lots of research has been undertaken looking at left atrial strain, and so we've got the terminology in terms of reservoir, conduit, and booster. And we really focused on this reservoir phase here. So in the bottom left-hand corner, you can see that image has just been clipped to just look at the reservoir function there. And this really focuses on the longitudinal function of the right ventricle, pulling that right atrium down, and in doing so, filling that chamber just prior to the passive filling phase into the RV, and then the final booster phase that comes through. So we really focused here on this reservoir measurement. And I guess the important thing to point out here when we come to look at the actual data is, unlike sort of traditional measurements of strain, where we look at RV strain, for example, this is a positive value as opposed to a negative value. So looking at the work that was done by Hasselberg and colleagues in 2021, what they did was measure right atrial strain in a group of patients with pre-capillary pulmonary hypertension, and they found that a cutoff value of less than 25% had a very poor outcome measure at 5 years. If we look now at our methodology trying to account for this, we maintain a pH register at the RUH, and this contains a lot of detail about these patients. So this is a retrospective assessment of this pH registry. We have the demographic details, we have the clinical history. Obviously, we've got extensive echo data as well, along with our right heart data. And importantly, what we've also got is the clinical outcome, so the final outcome for these patients as they've moved through this assessment pathway. And so what we did was we looked at the right atrial strain in this whole of this cohort using dedicated atrial strain software on the GE EchoPack version 204. And to ensure there was no sort of bias based on the known outcome, the operator was blinded to all of the measurements, so there was no bias going into this. This allowed us to do a subgroup analysis. So we took these mean right atrial strain values and broke them down based on the right heart cath data, so looking at the mean pulmonary artery pressure and the pulmonary vascular resistance, but actually also taking it back into the echo probability as well. So this is where it's going to be very practical for the sonographers on the shop floor doing the work. And this was based on the 2018 BSE guidelines. So the aim of the project really was to investigate the feasibility of right atrial strain in this retrospective cohort and see whether or not this can just help in the assessment of pulmonary hypertension and improving the test. We had some key key findings that we were looking at. So how successful was the measurement of right atrial strain in this real-world group? If the attainment is poor, then we know that this isn't going to be something that's feasible going forward. Compared to those with no pulmonary hypertension, because obviously within our registry we have patients who go on to have diagnosis of not pulmonary hypertension, was there a difference in the right atrial reservoir strain? And in those with pulmonary hypertension, did this strain value actually differ across the different etiologies of pulmonary hypertension, so pre or post-capillary pulmonary hypertension? And then taking the right heart cath data out of the equation and thinking about it from an echo perspective, when compared based only on the echo probability, did the right atrial strain differ? So is this going to be useful for the sonographer when they're doing the scan with the patient live there? So we started with 324 patients. We removed 19 of them due to atrial fibrillation, so 305 patients available, of which we were able to obtain right atrial strain on 258 of them. So that gave us an 85% success rate. And when we unblinded the results to look at which group they'd fallen into, we had 71 patients without pulmonary hypertension and 187 with confirmed pulmonary hypertension at right heart cath. And what that gave us was the two groups here. So we can see that the patients with pulmonary hypertension had lower right atrial strain values, so worse right atrial strain values compared to those without pulmonary hypertension. So when we broke it down to start looking at the different groups, what we can see is actually, so group 2, patients with PH secondary to left heart disease had significantly lower right atrial strain compared to those without pulmonary hypertension. If we take that out of the equation and look at patients with no pulmonary hypertension versus those with precapillary PH, so essentially pure pulmonary hypertension, if you like, again, we can see that there's a difference in the mean values of right atrial strain between those two groups. And unsurprisingly, when we compare the PH group versus the PH secondary to left heart disease, again, we can see that there's a difference between these two in the post and the precapillary groups. So if we remove the right heart cath data again and think very much practically about how we can use this when we're taking pictures in the clinic setting, we looked at the echo probability outcome, and in the patients with a high echo probability of pulmonary hypertension, we can see that their right atrial strain, reservoir strain was significantly lower compared to those with low right atrial strain values. We performed ROC analysis with error under the curve of 0.7, taking a cutoff value of 21.5%. We found that we had sensitivity of around 80%, but poor specificity at sort of 50. So, something to consider really in terms of the robustness of the measurement. When we looked at the right atrial strain values based on the echo probability, unsurprisingly, we can see in the high echo probability group, 50% of them had a reduced right atrial strain value using 21% or 21.5%. But what we're really interested in is this low echo probability group here, and this is really where all our research is focused in trying to improve the detection of pulmonary hypertension in this group here. And what we found is that 33% of this group actually had reduced right atrial strain, and when we looked at this in a little bit more detail, what we actually found was when you apply this back into the algorithm, so you take this group and you readjust the pH algorithm to include right atrial strain, 50% of these moved from the low echo probability group into the intermediate probability group, and they had confirmed pulmonary hypertension at right heart cath. So what we can see there is actually we end up with a shift of about 35% in those patients with an increased probability from low echo probability of pH into intermediate. So it's not perfect, but what it does do is help reduce the false negatives that we can see going on here. So if we envisage where this could sit in the future, we look at the future perspectives and consider that actually we could pop right atrial strain down in the bottom right-hand corner to go along with the new measurements and see whether or not this is actually useful in building a better idea of what's going on with the assessment of pulmonary hypertension to give a bigger spread across the different groups of the ventricles, the pulmonary artery and the IVC. So in conclusion, we found that RA strain was actually feasible in this real-world cohort, and I suspect if we repeated this again, just looking at the last year's data, that 85% would be even higher, because we've got images that have been acquired here on older machines. The optimization isn't focused necessarily on the obtainment of strain, so this is as robust as we could make it in terms of real-world data. Within this study cohort, right atrial strain is significantly lower in patients with pulmonary hypertension. And actually what it's very good at doing is differentiating PH secondary to left heart disease versus those with pure PH. So we need further work. This is a feasibility study, and we recognise that there are limitations in the data set that exist there. But what this says is that right atrial strain to us is something that we need to investigate further in a prospective analysis, utilise the imaging benefits that exist with the newer machines, but actually work this into the new PH guidelines, see whether or not that can actually help boost the detection and the sonographers on the shop floor doing the scans, and improve our assessment of particularly the low echo probability group patients. Thank you. Happy to take any questions.
Fantastic, James. Great presentation and a wonderful study. Just a quick one from me. In terms of the mechanisms for this, do you have any thoughts? Because, of course, atrial strain, as you alluded to, may well be directed and predominantly driven by longitudinal right ventricular function. So I'm just wondering, have you thought about the mechanisms as to why that might be more discriminatory?
So I think the thought process here was really surrounding why is the left heart disease group, why do they come out worse? And we conducted the analysis and included all of the patients with atrial fibrillation to begin with, and actually made all of the analysis even more significant. So we removed that out. So we recognised that the left heart has a massive impact on what's happening here. So suspect probably it's just a progressive degeneration in that longitudinal function on the left side that then causes the left heart disease. We like to think that in terms of pulmonary hypertension assessment, if you look at the guidelines at the moment, they're very much focused on the physical adaptations that have happened to the right ventricle. So you have to see dilation of a chamber, you have to see the PA becoming bigger, for example. Actually, there has to be a flow phenomenon that occurs first. There has to be a change in pressure or flow that's occurring within this system that we're just not being able to detect yet. And really, potentially the golden bullet is finding that at an earlier stage, so we don't have to wait for those physical adaptations to take place before the flow phenomenon has actually occurred. Thinking in terms of sort of a pulmonary hypertension cascade, really.
No, absolutely.
We have had another question come in, which actually, to be fair, I was going to try and nip in with as well, just because Dave would ask it otherwise. How reproducible is RA strain?
So we used the algorithm on the EchoPack software, and we found that I measured all of these patients. I had a cohort of patients that were measured by one of the colleagues, and actually the difference between the two was very reasonable, but we recognised that we're beholden to the features of the algorithm. So unlike when you measure strain on the LV or the RV and you have the option to change the different regions and adjust it ever so slightly, you are beholden to what the software is offering you. And so, of course, we know that the strain research says there's differences between the vendors and everything. In essence, the reproducibility was okay. I can't give you the specific numbers, but nothing that I would say would have changed the actual outcome of the study. But again, if we think about this prospectively, that's one of the things that we have to consider. Is this going to be reproducible in someone who's got a Philips system or someone who's using Tomtec as opposed to the GE algorithm that we were using that's obviously designed for the left atrium, not the right atrium, but it worked.
And just anecdotally, how feasible do you think it would be to adopt this into the guidelines and for sonographers to be able to undertake it on a regular basis?
Absolutely, yeah, I think really feasible. Again, obviously, you've got to have the software that's available to be able to do it, so that's a major limitation, and we're fortunate that we've got a number of machines with it on. And some of the research that exists out there have produced right atrial strain values, but what they've done is use the left, it's going like the opposite end of the spectrum, really, isn't it? They've used the left ventricle strain software to assess the right atrium. And so you end up with a segmental analysis, and then you have to average everything out. I don't think enough is known about that reproducibility and the impacts of the software algorithm itself. So, yeah, that's really a limitation, is the software has to be available. But practically, it was very easy.
I'd be really interested as well, it's more just a comment really about looking at that left heart group of, or left heart disease group of patients a bit further and seeing where they are in terms of their symptoms and their disease progress, and looking more at longitudinal data, because I think that could provide additional prognostic
I think
information.
that was a really interesting outcome that we possibly didn't anticipate was going to be quite as significant as it was, particularly when we then removed the AF patients to see what happened. It's arguments to say that you can still potentially measure reservoir strain in AF patients, but it was still very significant. And yeah, I think you're absolutely right. It's definitely a future area that needs to be considered.
Brilliant. Thank you so much, James.
Okay, thank you, James. Thank you.
Sorry, there was one question
Sorry.
about Dash.
Thank you very much for the presentation. Have you guys in your group have any thoughts on the how related the RA strain values are to the absence or presence of TR, or the ability of us measuring the TR velocity? Because we know we can't measure TR velocity in many of the patients, so that limits the use of the algorithm. Do you guys feel this could be an earlier marker or a way to use it independently from TR velocity, or just looking at it from the perspective of the diagnostic or probability algorithm?
It's a really interesting point. I think that's why this work needs to be designed from the ground up, really, to say, well, actually, we know that TR isn't available in everyone, and because the TR is not available, that limits you literally to the intermediate group only. And so there will be patients where we can't measure the TR that have actually got a high echo probability or have pulmonary hypertension. So designing the study from the ground up again, I think there's real scope to be able to do it. But to understand that, we have to be able to, use the new guidelines that have helpfully come out in the time we produce this work, but then also weight things based on their diagnostic accuracy. So it would be nice to think that we would be able to just use right atrial strain and not necessarily worry about TR, but I suspect it'll always have to be there in some form within the algorithm.
I think Dan's just got a comment as well. There's a microphone just coming to you, Dan.
Really good question, and the atrial strain is additive, actually. So in our low probability group, 10% of patients didn't have TR measurable and had pH, and over the whole cohort it was about 15%, a huge number.
Well, I think that's your next 10 years of work sorted out.
Thanks very much.
Thank you. So next up we've got Casey Johnson. He's here talking to us about the hospital costs following stress echocardiography in real-world setting in the UK, and it's a costing study from the BSE NSTEP multi-centre study. Thanks, Casey.
Yes, thank you. Make sure I've got my tools going here. Yes, so thanks to the BSE for inviting me to do this today. And yeah, we're going to just shake things up just a little bit. It's going to be less clinical and more about money. So they've sent the American, the capitalistic one, to talk about the money. So just bear with me there. But yeah, I think it's some very interesting data, so we'll take a look at that here. Get my clicker. There we go. Yes, so it is hospital costs following stress echo in the real-world setting in the UK, a costing study from Everest and BSE NSTEP multi-center study. So we're going to talk just a bit about some economic evidence based on some of the recent guidelines. So we have here the NICE guidelines, recent update in 2016 for the assessment and diagnosis of recent onset chest pain and discomfort of suspected cardiac origin. So basically what's happened here is the current NICE guidelines recommend CTCA as a first-line investigation for these patients, and that data has come from some of their health economic outcomes, and they've also done some of their own health economic modeling. And so this picture here is just an example of some of their decision trees that's gone into their economic modeling. But what's actually happening, and I think some people can agree because there's been data out about this recently, is that these guidelines might be a tad bit flawed and might contradict some other European Society of Cardiology guidelines. So the NICE guidelines concluded that CTCA has the lowest cost per correct diagnosis of CAD, but the authors themselves came up with a few limitations of this economic analysis, that it was modeled based on literature, and a good bit of that literature only included stress echo in about 1 out of 4 papers that they utilized in these guidelines. Decision trees with instant time horizon, only costs of the tests themselves and complications were considered, and there was no actual stress echo as a standalone strategy in these decision trees, and also weighted false positives and false negatives of equal value. And there's high heterogeneity in the meta-analysis for test accuracy, and no further sensitivity analyses in these test accuracies. And there's been recent papers out, one from the British Society of Cardiovascular Imaging that kind of talks about how in the UK, if we were to try to implement these guidelines, there'd be a big difficulty in that due to infrastructure, lack of capacity, lack of scanner capacity in the UK, and also the training that would be required for those to be able to take CTCA as a first-line investigation. And many of us know that stress echocardiography, we're able to usually have a high throughput, and the training might be a little bit easier, and the infrastructure across the UK might be already there. So the aim of this study then was to investigate the associations between stress echo accuracy in a real-world setting and cardiac hospital costs. So the idea was that perhaps if we're able to provide some real-world evidence on the actual costs downstream of stress echocardiography, that could be potentially used as evidence going forward for further policy or guideline amendments. And so yes, we looked at accuracy of stress echo in a real-world setting. So the bulk of this data comes from the Everest study. So here's a picture here of a recent publication from the earlier iterations of the Everest study, and I'll talk about the Everest study a bit in a moment. But something that we could pull out of that already is that the Everest study themselves published data on the sensitivity, specificity, and accuracy of stress echo practice across the UK. Now this here is around 5,100 patients. And so basically what this infographic is showing is that the sensitivity, specificity, accuracy that's come out of this rather large cohort of data from the Everest study is quite different than what the analyses from the NICE guidelines used as accuracy metrics when discussing stress echo. So perhaps that there's actually a bit better shout for stress echo than what these guidelines were showing. So the Everest study, just to give you a little flavor of what the Everest study, if we don't know, I think a good bit of us might be familiar, but the Everest study aims to provide real-world evidence about the accuracy and costs of stress echocardiography in the UK. So in this particular analysis that I'm talking about today, we have 7,636 patients from 28 trusts across the UK. I will put an addendum there that those are only in England. Patient characteristics and detailed clinical data are included within use of diagnostic tests and cardiovascular procedures, details of deaths. So we were able to have 12 months worth of follow-up data for these 7,636 patients. And with that follow-up data, we were able to take a look at what type of investigations these patients went on to had, which of those are cardiac, the costs associated with those investigations, and get a good, rich, detailed understanding of the pathway for a year after their stress echo. So some of the results we pulled out of that was the predictive accuracy of stress echo, resource use and cost of hospital services, and mortality as well. So with that, we were able to build a stress echo national decision tree. Now, I was not the one that built this tree. I will say that William Woodward is who built this tree, and it took him a very long time to do, but he did have it. It's just an idea here of what this decision tree looked like. So each one of those 7,636 patients would have had an individual node on this tree that tracked where they went after their stress echocardiogram. And at every node, it talks about the N number, and of course, each one of these investigations also have cost implications as well, and those are accounted for. So just an idea about some of the results that came out of this. So the average cost by hospital, we can just see these are the 28 trusts. So I use hospital trusts interchangeably, which is not actually accurate, but these were 28 trusts. And so we can see that there's a good variation in the downstream costs 1 year following stress echo across these hospitals. So the mean was £729 per hospital, standard deviation, as you can see, median and interquartile range, just to kind of illustrate that there is a big variation there. And the costs based on stress echo diagnosis. So I think this is some really interesting work here. So average hospital costs were broken into 12 months post-stress echo. So I appreciate this is a different number than the averages on the preceding slide. This is actually cost, the average per patient, and the previous slide was per trust. So per patient, stress echo, £646, broken into true positives, around £2,300, true negatives, 227, false positives, 1,400, and false negatives at around £4,000. So just to give you an idea of 12 months after the stress echo, for the varying types of diagnoses of their stress echo, these are the costs that we found 12 months prior were associated. So this is just to give you an idea of the causal pathway in the statistical analysis. So the predictive accuracy, was actually measured based on adjudication during the Everest cohort of validated against ICA and MACE. And you can just see a bit of the confounders here, which were adjusted for in this analysis at the patient level and both at the hospital level. For the interest of time, some of this isn't discussed, but there's actually some data out about the associations of these confounders with downstream hospital admissions and with predictive accuracy. And there's multi-level regression analysis was performed. So a bit about the associations of diagnoses with hospital costs. So a correct stress echo associated with a decrease in mean downstream costs per patient. So that's what we can see here on this plot. So stress echo that was correct was, associated with a decrease in ratio of mean hospital costs. That adjusted odds ratio, as you can see, And that resulted in a reduction of mean downstream costs of around £1,000. A false positive stress echo, on the other hand, was associated with an increase in mean downstream costs per patient with an adjusted odds ratio, as you can see here and based on the graph, and resulted in a mean cost increase of around £803. And then a false negative associated with an increase in mean downstream cost, as with false positive stress echo, but this resulted in a mean increased cost of around £1,400. So another bit that we did after that is we projected cost savings by increasing accuracy. So there was a regression analysis that was performed between predictive accuracy and average downstream costs that resulted in a linear regression equation that we could use to model the impact that changes in accuracy, if we tweak a bit, could have on these costs. And this is what you can see here. So if we're able to plug in a difference in accuracy, for example, we modeled what would happen with an increase of 1 percentage point of accuracy across the cohort in Everest. This was, a £57.30 saved per index stress echo. So this increase of 1% across all the Everest trusts would be roughly around 1.1 million annually. There were 19,166 stress echoes performed per year that was self-reported by the trusts that participated in the Everest study. So we took that across with this 1% increase to model what the cost savings might be with that increase of accuracy. And then we used a paper by Asher et al. That discussed more recently the Nabadiachara paper about stress echo capacity per year. So if we apply this to the numbers reported in that paper, which was 61,458 per year, then again that would be an estimated cost savings of around 3.5 million if this increase of accuracy of 1 percentage point was implemented. I appreciate that's a bit harder said than done, especially that the accuracy of stress echo already is proven from the Everest paper to be quite high, but we still modeled that anyway just to take a look. And also we did it one step further where there was around 15 hospitals in the Everest BSE and STEP study that performed lower than what the average stress echo was reported by the study, which was 94.2%. So if we were to increase the accuracy of each of these 15 hospitals to then meet what the average accuracy would be of that 94.2%, what would that result in? And that would result in an estimated cost savings of around 772,000, as you can see. And then a bit step up further, assuming that Everest and BSE and STEP is indicative of national accuracy, then if we apply this increase in accuracy to what we could say around 58 out of the 115 that were reported from this Asher paper, hospitals in the UK, that would result in an estimated cost savings of around 3.2 million. So just a few different ways of tweaking things here to come up with some relatively large numbers. So a few key messages then, the real-world evidence to improve economic evidence for guidelines. So as I mentioned, this is a real deep dive with a large number of patients at what exactly are the costs associated with stress echo 1 year after the stress echo, and that's something that wouldn't have been implemented into those previous NICE guidelines. And we did actually highlight that there is a substantial cost difference between false positives and false negatives, which most might be able to kind of understand why that might be, but that was one of the limitations that the authors of the NICE guidelines mentioned, was that they weighted false positives and false negatives equally when assessing the cost efficiency of stress echo, and that obviously is not the case. And we were able to provide a detailed description of the chest pain clinical pathway, which may inform further clinical planning. One thing that I didn't include for the interest of time, like I mentioned, were those different confounders and how each of them might be associated with accuracy and with downstream costs and downstream non-elective hospital admissions. So from some of that data that will be published later, we may be able to actually inform a bit more about clinical practice. And we obviously were able to kind of model potential cost savings from different tweaks of increasing accuracy of stress echo. And yes, that should be everything, so thanks for that. Thank you.
Just a few things that I would take away from that as kind of a BSE representative is that we have work to do to try and help the centres where we can improve accuracy. Have you started to look at what the differences are between those that met the diagnostic accuracy yield that you would expect versus those that didn't? For example, BSE accreditation or the workforce of the centres?
Yeah, no, it's really interesting point. So I don't think we've looked at anything per se about the accreditation. I know that there's a bit more into the data about IMD rank and a bit more about how many stress echoes are performed at centers annually and how many attendances there are, how many experienced, quote, consultants that might be there, and those things were able to show different associations with predictive accuracy. So the third bullet here is kind of a bit about that in the paper that will come out. Whichever of those, and I can't recall off the top of my head, were highlighted as being associated with potentially worse accuracy, is a point of view where we can then say, well, this is something that you might want to work on. This is something that we might want to look into a bit more. If the association with a poor accuracy was due to high throughput, perhaps that means that we're missing things because that too many patients are coming through at once. So yeah, that's been looked into a little bit. Obviously, there could be things to do with, like I said, IMD rank, geography, and again, this isn't indicative of the UK per se, as there's no Scottish or Welsh sites involved, so we'd have to kind of look into that as well. But yeah, definitely good food for thought of being able to pinpoint where there's room for improvement and go from there.
Yeah, brilliant. Anybody
Okay,
else?
we've got a question.
Yeah.
Hi, thank you very much, Casey. It's impressive work. Thank you.
Sure.
I have two questions.
Okay.
So first of all, how do you define accurate and not accurate stress echo?
Yep, so this would have been done, so in the earlier Everest paper that was published that had the 5,000 patients, it's mentioned in there actually, there's an adjudication process against all the patients that were included, and so there would have been a few different consultants who looked to see what the original stress echo diagnosis was, and then looked later, those 12 months, to see if there was any ICA, if there's any major adverse cardiac events, and they were able to pull against whether or not they considered that a referral was appropriate or inappropriate, and so they were able to determine what was correct, true, false, negative, based on events, basically 12 months down the line. And of course, a limitation of that means that if something happened after 12 months, that person wouldn't have been fit into the right category of their accuracy, but that's just a limitation of the study.
Thank you.
Yeah.
And the second question is that, so in your prediction model, you mentioned about, so if we increase 1% of accuracy, that would save, I can't remember the figure, is
Sure,
about
yeah.
£1 million
Sure.
or something. So I think if we're talking improve of accuracy, so we only focus on the patients in the non-accurate group, I presume. Is that correct?
Yeah, yeah.
So
So
if you already have accurate results, then there's no way to improve it.
yeah, of
So
course.
only in
Let's
the
see if we can-
non-accurate group, you improve the accuracy in that group. And out of your over 7,000 patients, only 450 are deemed as non-accurate. So if we improve only 1% of that 450, probably we're talking about 5 patients only. So that which means if we save, I mean, if there's no cost to all these 5 patients, we're probably only talking about maybe a £10,000 or if it's 1% accurate. So how do you derive this £1 million saving from your data?
Yeah, no, it's a fair point. I think I would need to look into it a bit further. So I wasn't really involved in this modeling. That was more the health economists that we have included as well. But I think it's a fair point. So I don't have an answer for you for that for right now, but I think it's something to look into, especially as we're still in the process of analyzing the results and drafting the work.
Brilliant. Thank
So
you.
yeah, thanks for that.
Thanks very much.
Thank you.
So one last thing, Casey.
Yep.
I mean, this is fantastic, and it's really, really useful. This type of work is so important. But I'm thinking probably outside of this study, but in terms of the technology to improve accuracy, what could be done, do you think, to improve that yield?
Well, this is where my lack of clinical knowledge of stress echo comes into play, to not know exactly what we could do to change those things. From my perspective, I think it'd be interesting to take a look and see, obviously that was an anonymized distribution of the costs, but you could see towards the right side of that graph, those costs at those particular trusts was quite a bit higher, and we'd have to look to see if that had any effect in their accuracy or what the individual accuracy was at trust by trust, which we do have that data for. So then potentially taking a look further to see perhaps things that Maria mentioned, the accreditation at those places, which types of things. So it maybe isn't technology, it maybe is technology. It also might be that perhaps these are older scanners or different vendors. We haven't looked at the differences between vendors, but I know, for example, with a lot of the site visits I've done for the studies that I've managed, the model of the systems that are in use vary quite heavily from things back in 2010 to things now. So something to look into. Not that I have the answer for that now, but definitely could have a factor.
Yeah, no, absolutely. I'm thinking as well along the lines of some artificial intelligence, maybe.
Yeah, no, definitely. So that's also something that I'm working into and some other stuff that I work in. So yeah, so artificial intelligence obviously is kind of one of those buzzwords around here that can help improve accuracy, and then that trickles down to thereby reducing health costs. So that's something that could potentially be implemented. And I guess I'll give a shout out to the ultrasonic study, the Proteus study that's currently going on, that is looking at stress echo accuracy and AI intervention. So yeah, perhaps we'll look at the end of that study to see how the AI might have changed accuracy, and that could be something that's utilized to do this model increase of accuracy.
Fantastic.
Yeah, thanks.
Thanks.
Oh,
Thank you.
no, that's fine.
That's fine, go ahead. Oh, hello, yeah. Thanks, Will.
So obviously accuracy is key here. With the, I guess you've got 50% more data now from the Everest study.
Mm-hmm.
Are we seeing like higher accuracy in one modality, i.e. exercise or pharmacological, use of contrast? Are there some key factors that are really driving that accuracy that could drive the cost savings?
Yeah, no, it would be interesting. So I think because of the fact that the Everest study is still currently recruiting and not finishing until September, we haven't been able to snapshot that again. So that initial paper of that 5,000 or so patients, I do believe goes into a bit more in depth about the different, exercise stress echo versus pharmacological stress echo. So currently, yes, the Everest, I'll go ahead and mention, by the time we end the Everest study in September, we should have upwards of 15,000 patients. So we'll definitely be able to take a look in a little bit further and see where that's kind of sussed out, because we do record whether or not it's an exercise stress or a pharmacological stress echo. So basically, to say that paper of the 5,000 patients will be replicated again with the 15,000 patients to give a bit better insight into that, and the rest will follow suit. But we don't have that quite yet. But hopefully it still stays quite accurate.
Okay.
Brilliant.
Thank you.
Thanks,
Yeah, thank you.
Okay, so our final speaker is Mohammed Sahib. His talk is left ventricular ejection fraction measured with same-day echocardiography and CMR in patients with suspected cardiotoxicity.
Thank you so much. First of all, thank you for the invitation, and it's an absolute privilege to be here today at the British Society of Echocardiography to present this work on left ventricular ejection fraction measured with same-day echo and CMR in patients with suspected cardiotoxicity. My name is Sohaib Nazir. I'm a clinical lecturer and a cardiology SPR at King's College London and the Royal Brompton Hospital. I have no relevant financial disclosures. I appreciate I'm holding you all from coffee, so please bear with me, okay? And that includes yourselves as well. So the first slide I want you to show, I'm going to ask you, do you think the ejection fraction is 50% or more or less than 50%? That's it. Or just a binary cutoff, and I'm going to show you 3 cine loops. So just to remind you, 50% or more or less than 50%. So let's ask, and the panel can also contribute as well, 50% or more.
More.
Okay, so 50%, less than 50%. Okay. How about here? I'll let this run for a few seconds. 50% or more or less than 50%. 4, 5. So 50% or more, less than 50%. Great. Okay. Let's go to this case. 50% or more or less than 50%. And I'll let this run for 5 seconds. 2, 3. And there you are in your Friday 4:30 p.m. slot. 50% or more, hands up. Less than 50%. I'm really glad we've got a split there. So this is really trying to show you, the left and the right are easy. This is something we do on a day-to-day basis. The one in the middle is really hard. And really, echocardiography lies on the spectrum on assessment of left ventricular ejection fraction. And the one in the middle is the core of the work of cardio-oncology. And this is why this talk is extremely relevant to all of us today and everyone downstairs on the 3rd floor. Cardio-oncology today, I'm going to talk about cardiotoxicity, and specifically today just on cardiac dysfunction related to cancer therapy, not the other pillars as shown in the slide over here. We now have fantastic guidelines on the management of cardio-oncology patients. We've got the first ESC guideline, not the position paper, on management of cardio-oncology patients. We also have a very fantastic BSE guideline And the most important thing I want you to take away, reflecting back on that second slide I showed you, is that the threshold of 50% is important. You'll just wonder where I might be coming to over here. So, I've already told you that cancer therapy patients are given chemotherapy and radiotherapy, and that may cause cardiac-related dysfunction. And that's best assessed using left ventricular ejection fraction. You know that echo is the most widely used tool for lots of reasons: cost effectiveness, ease, accessibility, but also CMR is probably the gold standard for volume ejection fraction. And therefore, the objective of the study is to determine agreement between 2D echo, 3D echo, cardiac MRI, but more importantly, to assess the impact on downstream clinical decision-making on patients. This is a single-centre prospective clinical study at Royal Brompton Hospital where patients underwent same-day echo and CMR. So that's same-day echo and CMR, and they were all performed according to BSE guidelines or EACVI or SCMR guidelines by someone who's accredited in BSE or by SCMR. All patients had 2D echo and CMR, a subset had 3D echo, and we importantly have ethical approval to undertake the study from the Health Research Organisation and the Guy's and St Thomas NHS Foundation Trust. Let's go on to our results. We have an impressive 745 patients included in the study, mean age 60 years, 62% female, and this table on the right shows you the wide range of cancers that we included in these patients. First headline figure. This is a Blant-Ortman plot, which I'll walk you through. Okay? So this is 2D echo and CMR-derived LVEF, 745 patients. X-axis, the mean LVEF of CMR and echo. Y-axis, the absolute difference between 2D echo and CMR. The blue dotted line is the mean bias, which is about 3%. Doesn't look that bad. But probably the most important thing to take away from this slide is the red dotted lines over here, which are the 95% limits of agreement, which indicate the larger variability between CMR and echo. So we're looking at plus minus 15% from the mean bias. So who cares about that? So we've shown lots of Blant-Ortman plots today. How does this impact on my clinical decision making? Who cares about the limits of agreements I've talked about? Let's go back to that first few slides I showed you, that cut-off of 50%. If we use this Sankey diagram to classify which patients agreed with both modalities, you can see most patients agreed. So, sorry, in most patients it agreed. So where echo and the CMR was normal, or the echo and CMR was abnormal. But you can see, using the Sankey diagram, that there's about a 9% discordance where there was a disagreement in one of the modalities. So does that mean we should stop doing echoes? That's absolutely not the message to take from here, and I'll tell you why. Next slide shows you in a sub-study analysis of patients who also underwent 3D echocardiography, and you can see that there was better agreement and no significant difference between LVEF measured by CMR and 3D echo, but there was with 2D. That's figure 3 to take home today as well. Now, just going to wrap up. The limitations need to be acknowledged. It's a single-centre study, right? There's some referral bias here because we scanned patients who were referred for cardio-oncology assessment rather than all patients who've got cancer. So there's some patients who probably don't make it into that service. Now, I'll be very upfront. We didn't undertake a repeatability study, but these have been very, very, very well published before, including from our own group from many years ago. So those are kind of things that are already been well established. And really today, I want you to take away that actually there's about a 10% disagreement in patients with LVEF with 2D echo and CMR. There's a small bias, but actually there's a large limits of agreement, plus minus 15%. There's better agreement of 3D echocardiography, and that's why we should really be using 3D echo in these patients. And it really highlights that if we don't, there's a potential for downstream impact on clinical decision making and cardio-oncology care. Last slide before coffee. And I'll show you why this is important. So let's go back to what we talked about right from the beginning. Got a cancer patient who's referred to you, gets referred to a cardio-oncologist. That cardio-oncologist then undertakes some sort of imaging. Again, echo is first line, so they'll undergo an echocardiogram. If the ejection fraction is normal, that's great. They go ahead and have their cancer therapy. And that saves lives. It improves prognosis. Well-defined cancer therapies, far more than probably what we do in cardiology, I have to say. What happens if they've got a low ejection fraction? Below with what would allow from FDA guidance, for instance, with anti-HER2 therapy, as an example. That means they stop their anti-HER2 therapy, for such with the Herceptin or trastuzumab. We then start them cardioprotection. All this time is ticking. All this time, the ejection fraction by that imaging test was crucial. And that's why, if we just go back to that first slide, where did you sit between the 50%? Were you above or below? We had a 50% split by there. Some very good experts in this room, I have to say. We need to have a crucial assessment of left ventricular ejection fraction for cardio-oncology patients, and 3D echo is the way forward. I have about 45 seconds left, 33 seconds left. So I'll just finish by first of all acknowledging all my co-authors, all the funders involved in this study, most importantly, the patients involved in the study, and I have to say also my 3 children who are very upset with me this morning because I didn't take them swimming. So thank you very much. And I'm very happy to take questions today or later if anyone has some.
Thank you. That was a fantastic presentation, and I think it was definitely over 50. Have we got any questions from the floor? Quick questions.
That's good.
I just wonder what happened to that 10% of patients who had this group between echo and CMR. How many of them actually got had for treatment, how many of them stopped it?
Yeah, really good question. I'm not sure if I'm allowed to say that data yet, but it is in the paper that we've written. So I think rather than saying that, what we should probably think about is actually there was a delay to treatment for some of these patients. So we're looking at about an 8% of these patients, there was a delay to their treatment. And that subsequently meant that there was further imaging tests done, blood tests. It's not just all about left ventricular ejection fraction, as you know. And in the end, they were starting cardioprotection like I showed you in that last slide. But then at the same time, time is ticking. Time is ticking. So the answer to your question is about 8%. Dr. Augustine.
So a really nice study. I think you're blessed with a great MRI team, aren't you? I work in a DGH and we have an okay MRI service, but many people will struggle to get patients to MRI, and that's one thing to think about. I completely agree with you about 3D echo, and the other thing we do is contrast echo, actually. So those ones that are borderline, contrast is useful, and the blood biomarker is really useful up front at an early stage when you think the EF's going down. But really nice. But how do you think this is going to be applicable in terms of a real-world service?
So I think, first of all, to be very upfront, I don't think MRI is the answer, because that is the wrong thing to take away from this study. I think MRI is, so I'm also level 3 in MRI, but that doesn't mean I'm advocating to. I think MRI is just too expensive for this specific test. It's £745 in London. The market rate is about, going back to cost effective, it's about £550, whereas a standard 2D echo, unfortunately, the rate is really, really quite low, and we're not getting reimbursed for it, but it's about £70 if I'm not correct. So I think from clinical applicability, where we should be taking this forward, is that we should be using 3D echo as standard of care. Now, that has challenges in itself, because actually we also need the infrastructure to do that, the hardware to support that, and also the software to support that. But I just want to show you that first slide. I'm really glad to be here today, because I want to show you the kind of problems you can get into when you're above or below the 50%. I haven't talked about GLS today, because actually, and I'm taking this on head on, is actually when you speak to an oncologist, when you tell them about GLS, they get really confused. They say, how can you have a negative number? that talks about how efficient your heart is. And because they talk all in positive numbers when they look at their nuclear medicine, yeah, the FDG ratio SUV is about 9.9, that means they've got cancer. When you're dealing with GLS numbers, it can get really tricky. And when you look at LVF, this is a quote from one of the oncologists that I speak with, LVF is king. And without an accurate LVF, all of their guidelines, I know we have our own guidelines here, but in terms of FDA approval and guidelines for drugs such as Herceptin, it's all based on left ventricular ejection fraction. Again, so I haven't gone into a really fancy, detailed novel biomarker today, but I'm just going to come back to a really important thing that's really applicable to us all. And going back to your question, what should we take away from today? I think 3D echo should be the way forward for cardio-oncology patients.
Thank you. I've actually got a note here. I know you said, should we stop doing echo, but I've written, should we stop doing CMR? So I think you're right, in this cohort, that might not be the right thing. And I remember when fractional shortening was king. And at least now it's ejection fraction, and hopefully it'll be GLS and 3D one day. So.
Absolutely. I really hope at some point it will be GLS and 3D. That really is the way forward. But it's also about, we're sitting here in one ivory tower at the BSE, which is the pinnacle for echo. I know there's a lot of oncologists who don't understand numbers. I had an email yesterday evening at 4:59 when I was leaving over here, saying about a patient whose ejection fraction was 47% on the MUGA scan, and the Herceptin's been stopped. Brian's shaking his head there because he knows what the variability is with the MUGA scan and 2D echo. It's about 20 to 35% compared to 2D echo. And I just said, please don't stop the Herceptin. We'll get them in for an echo on Monday morning and give you that reassurance. Again, highlighting how we as an echo community are going to be really instrumental going forward with all the massive cancer therapies that are going to be coming forward in the future.
We've definitely got a lot of work to do in this area. I'm sure you'll be contributing a lot.
I'd love to.
Thank you so much.
Thank you so much.
Thanks so much, everyone. Thanks to all our speakers. That'll wrap up this session. But if I can just remind everybody it's the poster session now. So people will be walking around and hopefully coming to check out your posters. So please get engaged with everybody. But thank you so much. That was brilliant.